Hi everyone. The video is off for today, but I want to record your lecture on the care and management of the critical patient with burns. The content that you will find helpful is Bruner and Stark's chapter 57. There is also some information about chemical burns other parts of the skin unit. I would also remind you to look at skin assessment because you'll need to know that. So, we're going to start with an overview of burns. The definition of a burn is damage to the skin or tissues caused by heat, chemicals, electricity, or radiation. The impact is that it's painful, it's costly to the patient and the healthcare system. It is disfiguring, and that will you want to be mindful of that when you're coming at this from a holistic point. And then burns often lead to long term disability and require extensive rehabilitation. The global burden of deaths is that there is approximately 180,000 deaths annually, and many burns are preventable. The common settings for burns are going to be home and in the workplace for those occupational burns. The incidence of burns is that we have 486,000 burns treated annually, 40,000 burns end up hospitalized. Causes are going to be flame related, scalds, direct contact, electrical, chemical, inhalation, and miscellaneous. The demographics are going to be men are greater than women, so there's a 2-to-1 incidence, and the highest prevalence is going to be in adults aged 20 to 30. 73% occur at home, 8% in industry, 5% recreationally, and 14% are other. And as far as the hospital stay, these patients have a prolonged length of stay, historically estimated as 1 day per percentage of the TBSA, total body surface area, but it underestimates the length of stay, especially for patients greater than 40 or with inhalation injuries. The pathophysiology and treatment advances are going to be it's a complex multi-system impact. There's challenges. Um, burns really challenge health systems despite reduced comorbidities and length of stay. Key advances are going to be critical care management. We've made great advancement in that. We understand fluid resuscitation, and we're going to teach you that as well. We understand the role that nutrition plays in burn treatment, surgical debridement, wound coverage, and different antimicrobial therapies. And the nurse's role in all of this is going to be provide holistic, evidence-based care across all recovery phases to optimize outcomes. So, the nurse's role for burns is we want to educate on burn prevention in community and home settings. The WHO recommends that we raise awareness of burn risks and burden. So, some of the ideas that your book noted for prevention strategies are going to be keep matches, lighters away from children, never leave children unattended near fire or water, install or maintain smoke and carbon monoxide detectors, change batteries annually, practice home fire drills, set water heaters to less than or equal to 48.9 degrees Celsius or 120 degrees Fahrenheit, especially if you have children in the home that might turn on the water without you. Avoid smoking in bed, using oxygen while smoking, or falling asleep while smoking. Avoid flammable liquids near fire. Be cautious with hot car engines. Sorry about that. Um, be cautious with hot car engines, electrical wires, and hot appliances. Store flammable liquids away from fire sources. Be mindful of loose clothing while cooking, and keep fire extinguishers at home and know how to use them. We also have to consider some gerontological considerations. So, the risk factors here are age related changes. These patients have reduced mobility, so they can't get away, reduced strength and coordination, making it hard to navigate while a fire is present, reduced sensation, so that means they're more likely for scalds, vision and memory. So, again, those other things. Older adults greater than or equal to 60 years of age account for 15% of burn hospitalizations. Fire and flame sources cause 56% of burns in older adults. Higher mortality is higher in older adults, about 13% mortality for ages greater than or equal to, I'm sorry, yeah, greater than or equal to 59 versus 2.9% overall. And the lethal dose 50 is 30 to 35% TBSA for 50 or for older adults. So lethal dose 50. Hi, sorry about that. My husband decided to leaf blow while I was trying to record this. So lethal dose 50. So the evidence shows that if a patient is burned greater than 50% or greater than, their mortality rate spikes. But for with older adults, it's 30 to 35% TBSA for older adults. So that's what that means. Complications for these patients post burn are going to be pneumonia, urinary tract infections, respiratory failure, septicemia, cellulitis, wound infections, kidney injury, arrhythmias, and hospital acquired infections. Frailty and comorbidities increase risks even with small TBSA burns. These patients also have physiological challenges, so they have thinner, less elastic skin, which would mean deeper injuries and slower healing. They have impaired pulmonary function, which would mean that their pulmonary function would be worsened by smoking. Older individuals have decreased cardiac output uh, and coronary artery disease, which means higher complication risks. There's a fine balance between fluid resuscitation and overload in this population, and you'll understand that as we get through this lecture. Older individuals have reduced kidney and hepatic function, which means that they alter that medication clearance, which you should have covered in pharmacology. Older adults have malnutrition, which is going to lead to increased morbidity and mortality. And then they have mental capacity issues, such as challenges in pain, anxiety, and delirium assessment. These individuals also have polypharmacy, which is common due to comorbidities, and it increases complications and need for post acute care. The nursing interventions for this patient population is we're going to assess their ADLs and their IEDLs. We're going to modify environments for safety and refer to appropriate resources. And I know you covered peds, but I just wanted to make sure that I covered it here as well. So we have risk factors for pediatric considerations when it comes to burns too. So we have developmental factors. These patients are curious and they lack awareness of danger, which will increase that burn risk. Common causes for kids are scalds with the hot liquid, contact burns where they touch hot surfaces, most likely the stove, and flame related burns. Younger children are more prone to burns due to limited motor skills and inability to escape hazardous situations. Then we also have environmental factors where burns often occur at home, in the kitchen, or the bathroom. And then we also have unsafe practices. So, like, people might leave their hot liquids unattended, like a coffee that they just poured, or improper use of electrical appliances, or a lack of childproofing. So, the incidents for children are going to be children under 5 are at the highest risk for scald burns because they just start to get into the bathroom and turn on that water. And then flame related burns are more common in older children. Common causes, again, like we said, were scalds, hot water and beverages, contact burns, stoves or irons, flame burns, matches and lighters, and electrical burns, outlets and cords. There's a lower mortality compared to adults for children. Children generally have better survival rates than older adults. However, severe burns that greater than 40% TBSA can still be life threatening. So the lethal dose 50, so I talked about that in the last slide. We have a higher TBSA tolerance compared to older adults, but it varies by age and overall health. Most common complications with burns are going to be infections with like wound infections and cellulitis. We can have respiratory complications like an inhalation injury or pneumonia, fluid and electrolyte imbalances due to larger body surface area to weight ratio. And then other complications would be scarring and contractures affecting growth and development. So when you think about a scar, like I'm sure you're all aware of what scarring looks like, but when you have a small child and then you have a burn that results in a scar, you then, as the child grows, now you have to deal with that scar, and there's often lots of surgeries that go in with that scar. And then there's also psychological trauma like anxiety, PTSD, or even psychological trauma around the way that they look. If they have a burn on the large portion of their leg, they might be a little bit more self conscious when with other kids their age. And then we could have delayed healing due to immature immune systems. So, we're gonna pediatrics is a big content. So, um, children have a larger body surface area to weight ratio, which means that they need higher fluid and caloric needs during resuscitation and recovery. Their head is proportionally larger than in younger children, which means a higher body surface area if the head is implicated. Their skin characteristics are that they have thinner skin, so much like the older adults, they're deeper burns with less exposure to heat, and there's a higher risk of fluid volume and hypothermia. They also have an immature organ system, so the kidneys and livers might not metabolize medications efficiently, much like the gerontologic population. And then they have immature immune systems where they have a higher infection risk. For their growth and development, burns can disrupt growth plates, leading to long term deformities, and scarring can restrict movement and affect physical development. Your nursing interventions, if a child is burned, is you want to do the fluid resuscitation. So you want to use pediatric specific formulas like the Parkland formula would be adjusted for weight and body surface area, and we want to monitor for signs of fluid overload and dehydration. In pain management, we want to assess pain using age appropriate tools like a FLAC scale for younger children. We want to administer analgesics cautiously, considering weight and organ function. We want to use gentle techniques to minimize trauma for wound care. And then we also want to monitor for signs of infection. And then for their nutrition, we need to provide high calorie, high protein diets to support healing and growth. And we need to monitor for malnutrition, especially in prolonged hospital stays. When we support these patients psychologically, we need to address fear and anxiety and trauma through age appropriate communication and play therapy. We need to involve family in care to provide emotional support. Then we need to educate the family, right? So we need to teach them burn prevention strategies and provide guidance on home care and follow up appointments. Key strategies for prevention for children is that we need to supervise children around hot liquid stoves and electrical appliances, set water heaters to less than or equal to 48.9 degrees Celsius or 120 degrees Fahrenheit to prevent scalds. We want to install safety gates and keep children away from fireplaces and heaters and educate families on fire safety. The key takeaways for all of this information that I just gave you is that children are at high risk for burns due to developmental and environmental factors. Physiologic differences require specialized care. Nurses play a critical role in fluid resuscitation, pain management, wound care, and family education, and prevention is key to reducing pediatric burn injuries. So now we're gonna do what I call knowledge synthesis. So I've incorporated questions into our PowerPoint so that we can get better at answering questions. So our question here is: a 2-year-old child is admitted to the hospital with second-degree burns covering 15% of their total body surface area caused by a hot liquid spill. Which of the following nursing interventions is the priority during initial management of this patient? Do we want to administer IV antibiotics to prevent infection? Do we want to initiate fluid resuscitation using the Parkland formula? Do we want to apply topical sulfadazine to the burn wounds? Or do we want to provide emotional support to the child and family? The correct answer, and I hope you all got it, is B. We want to initiate fluid resuscitation using the Parkland formula. And I'm going to dive a bit into the rationale so that you understand. Fluid resuscitation is the priority. This was a priority question, it highlighted priority. Burn injuries, especially in children, can lead to a significant fluid loss due to increased capillary permeability and evaporation from the wound surface. Children have a larger body surface area relative to their weight, making them more susceptible to hypovolemic shock. The Parkland formula, which we will get into later in this lecture, is used to calculate fluid requirements for the first 24 hours post burn, with half given in the first 8 hours. So, why wasn't it administer IV antibiotics? Antibiotics are not typically given prophylactically unless there is a confirmed infection. Early use can lead to antibiotic resistance. So, we all want to be antibiotic stewards and not just give antibiotics prophylactically. Why would we not apply topical sulfadazine? While topical antimicrobials are important for wound care, they're not the priority during the initial phase of burn management. Fluid resuscitation takes precedence. And then why is it not provide emotional support? Emotional support is important, but it is secondary to stabilizing this child's physiologic conditions. The initial management of burn injuries, especially in pediatric patients, fluid resuscitation is the priority to prevent hypovolemic shock and maintain hemodynamic stability. This aligns with the ABCs of emergency care. This question is designed to test your ability to prioritize interventions based on the patient's immediate needs and pathophysiology of burn injuries. So now we're going to dive into nursing assessment of the integumentary system concerning burns. The integumentary system, which includes um, sorry about that, there was more noise. So, nursing assessment of the integumentary system concerning burns. The integumentary system, which includes the skin, hair, nails, and mucous membranes, plays a critical role in protecting the body from external threats. It also regulates temperature and provides sensory input. In patients with burn injuries, a thorough assessment of the integumentary system is essential to determine the extent of injury, identify complications, and provide treatment. In this section, we will cover key components of a nursing assessment for burn patients, including health history, physical examination, and special considerations for burn injuries. Health history. A comprehensive health history is the first step in assessing a patient with burn injuries. The nurse should gather information about the following. We need to know mechanism of injury. You will find that in all emergency care, we really focus on the mechanism of injury. So, the mechanism of injury is going to be the cause of the burn. So, would that be thermal, electrical, chemical, radiation? We just need to know what the cause is because the cause is going to indicate the treatment. Then we also need to know the duration and intensity of exposure to the causative agent, because again, that will that will create guidelines for treatment. And then the environment where the injury occurred, home or the workplace. Because you have an in if you have a fire, a structure fire, and the person was in the room where the fire started, then you worry about inhalation injuries. So that's why the environment is super important. Then we have patient's medical history. So, are there some chronic conditions that may affect healing? Because we know that comorbidities are going to cause the patient to have complications. Is there a history of skin disorders, allergies, or previous burns? Because then we have to deal with more types of scarring or problems healing there. And then, does the patient take any medications, including over the counter and herbal preparations that may impact skin integrity or healing? Then we want to move to a family history. So, does this patient have a genetic predisposition to skin conditions or keloid formation? That's super important when we talk about scarring. Then we would move to symptoms. What is the onset, location, and severity of pain? Is there itching? Is there discomfort? Do we have presence of blisters, swelling, or drainage? And then we would move to the psychosocial factors. So, how is this burn impacting the patient's emotional well being and daily activities? And then, what kind of support systems are available to this patient? So now we'll move to physical assessment. The physical assessment of a burn patient involves a systematic examination of skin, hair, nails, and mucous membranes. The room should be well lit and warm to ensure patient comfort and accurate observation. Always remember the environment should be warm. So for inspection, we want to note the skin color. We want to assess for erythema, pallor, cyanosis, or jaundice. In patients with dark skin, we want to look for subtle changes such as a grayish or ashen hue. We want to note areas of hypopigmentation or hyperpigmentation, which may indicate previous injury or inflammation. We want to note the burn characteristics. So we want to determine the depth of the burn, whether it's superficial, partial thickness, full thickness. And again, we'll talk about the classification of burns later. We want to assess the size of the burn using the rule of nines or the Lund Browder chart for children. Again, we'll talk about that later. And then we want to identify the pattern of the burn. Is there splash marks, glove and stocking distribution, and electrical burns? And if I say something like splash marks or glove and stocking distribution, please look that up. Okay. Lesions or wounds. Are there any lesions or wounds on the skin? We want to observe for blisters, eschar, or open wounds. We want to note the presence of drainage and odor, which may indicate infection. Is there any edema present? Check for swelling, especially in circumferential burns, which can compromise circulation. Circumferential burns are a key finding. If you have a circumferential burn, you have a problem. So look for those. And then we move to palpate skin temperature. Is there increased warmth? Because that may indicate infection or inflammation, and coolness may suggest poor perfusion. And then let's talk about feeling for skin texture and turgor. We want to assess for dryness, roughness, or tightness, which may indicate dehydration or scarring. We want to evaluate skin turgor by gently pinching the skin. Delayed return to baseline suggests dehydration. And then for pain, we want to use a pain scale appropriate for the patient's age and cognitive ability. We want to note areas of tenderness or hypersensitivity. Then we'll move to a vascular assessment. So we're going to use capillary refill for this. We want to press on the nail bed or unaffected skin. Refill time greater than 2 seconds may indicate poor perfusion. And then we want to check peripheral pulses in extremities with circumferential burns to assess circulation. For nail and hair assessment, we want to look for clubbing, which may indicate chronic hypoxia, assess for Bowes lines or pitting, which may reflect systemic illness or trauma, and then note singeing or hair or loss of hair, which may indicate the severity of the burn. Special considerations for burn patients in an inhalation injury. We want to assess for singed nasal hairs, soot in the mouth or nose, hoarseness, or stridor. We want to monitor for respiratory distress or carbon monoxide poisoning. If you have an NCLEX question or a test question that has anything to do with singed nasal hairs, you want to prepare for intubation. For fluid status, you want to evaluate for signs of hypovolemia or fluid overload. You want to use your urine output as an indicator of adequate fluid resuscitation. So, know what that key marker is. You want to monitor for signs of infection, such as increased redness, warmth, swelling, or purulent drainage. You want to assess for systemic signs of infection. And then you want to assess for anxiety, depression, or post traumatic stress related to the burn injury. Provide emotional support and could refer to counseling or support groups as needed. When we talk about documentation of our assessment, we want to make sure that accurate documentation is performed because accurate documentation is critical for tracking the progression of burn healing and identifying complications. We want to make sure that we describe the burn. We want to note any changes in color, texture, temperature, presence of edema, drainage, or infection. We want to note patient's pain level in response to interventions, any signs of impaired circulation or respiratory compromise. And then remember, our key takeaways from the assessment stage is that a thorough integumentary assessment is essential for identifying the extent of burn injuries and guiding treatment. Nurses must be skilled in recognizing subtle changes in skin color, texture, and vascularity, especially in patients with dark skin. Regular reassessment is necessary to monitor for complications such as infection, fluid imbalance, and psychological distress. Documentation should be detailed and accurate to ensure continuity of care and effective communication among the healthcare team. By integrating these assessment techniques into practice, nurses can provide comprehensive care to burn patients and improve outcomes. So we're back in our knowledge synthesis. A nurse is assessing a patient with burn injuries. Which finding would most likely indicate a potential complication requiring immediate intervention? Mild erythema around the burn wound edges, capillary refill of 3 seconds in the affected extremity, purulent drainage with a foul odor from the burn wound, dry, flaky skin in areas surrounding the burn. If your answer was C, purulent drainage with a foul odor from the burn wound, you are correct. These are classic signs of infection, which is a serious complication in burn patients. Infections can delay healing, increase scarring, and lead to systemic issues such as sepsis. Immediate intervention, such as a wound culture, antibiotics, and possible debridement, is required. So now let's talk about why it's not the other options. Mild erythema around the burned wound edges can be a normal part of the inflammatory response to healing and does not necessarily indicate a complication. Capillary refill of 3 seconds in the affected extremity is not the correct answer because delayed capillary refill, so less than 2 seconds, may indicate poor perfusion. It's not as urgent as an infection. It would require monitoring, but not immediate intervention unless accompanied by other signs of circulatory process. I'm sorry, that's greater than 2 seconds. Capillary refill greater than 2 seconds may indicate poor perfusion. 3 seconds is greater than 2 seconds. but it's not as urgent as the infection. And then dry, flaky skin is in the area surrounding the burn is not the correct answer because dry skin is common in burn patients due to loss of moisture barrier function. It can be managed with moisturizers and is not an immediate concern. In burn patients, signs of infection are critical findings that require prompt intervention to prevent complications such as sepsis or delayed healing. This question tests your ability to prioritize findings and recognize urgent complications in burn care. Now we're going to move to classification of burns. We're going to cover classification of burns in class as well. So, why do we classify burns? Burn classification is a critical component of burn management because it helps healthcare providers determine the severity of the burn. Where we understand the depth and extent of tissue damage, it will help guide treatment decisions. We can use it to predict healing time. Superficial burns heal faster than deep burns, which may require surgical intervention. I'm sorry, that was crazy. Um, we identify complications by classifying burns. So deeper burns are more likely to cause scarring, infection, and systemic complications. And then it helps us allocate resources. Classification helps prioritize care, especially in mass casualty incidences or resource limited settings. The classification system was developed based on layers of the skin affected and the extent of tissue deconstruction. It has evolved over time with advancements of burn care and a better understanding of healing. Burns are classified into four categories based on depth. We have superficial, partial thickness, full thickness, and deep burn necrosis. Each category has distinct causes, skin involvement, clinical manifestations, wound appearance, and treatment approaches. So a lot of you are wondering why, I'm sure. It doesn't say first degree first, it says superficial. So we have transitioned in the medical world away from using terms like first degree, second degree, third degree, and fourth degree to classify burns. It's been a gradual change. The shift toward more descriptive and clinically relevant terminology began in the late 20th century and continues today. Um, in the 80s and 90s, burn care professionals began advocating for more descriptive terminology that better reflected the pathophysiology and clinical implications of burn injuries. The terms superficial, partial thickness, and full thickness gained popularity as they provided more accurate descriptions of burn depth and healing potential. Modern burn classification systems emphasize anatomic depth and functional impact. Um, so that's why we changed the name. So when we're talking about superficial burns, that is what you might know as a first degree burn. So the cause is going to be sunburns, low intensity flash, superficial scald, like brief contact with hot liquids. The skin involvement is going to be only the epidermis, the outermost layer of the skin, would be affected. The clinical manifestations are going to be tingling, hyperesthesia, pain that is soothed by cooling, peeling, and itching during healing. The wound is going to look reddened and it's going to blanch with pressure. It's if you've ever touched a sunburn and it turns white, that's what it means, blanches with pressure. Dry with minimal or no edema, and it will be negative for the Nikolsky's sign. The recuperative course and treatment, complete recovery is within a few days. We'll give oral pain medications such as acetaminophen. Cool compresses and skin lubricants are going to be aloe vera. And topical antimicrobial agents are not indicated. Now we move to partial thickness. The cause is going to be scalds, flash flame, contact with hot objects. The skin involvement is going to be the entire epidermis and varying portions of the dermis. Clinical manifestations are going to be pain and hyperesthesia, sensitivity to air currents, blister formation. The wound is going to be blistered, mottled red base. You're going to have disrupted epidermis with a weeping surface. Edema is present. The recuperative course and treatment is going to be healing, typically occurs in 2 to 3 weeks. Some scarring and depigmentation may occur, may require grafting of the dermal injury. If the dermal injury is deep, and treatment includes wound cleaning, topical antimicrobials, and non adherent dressings. For full thickness burn, we're going to have flame burns, prolonged exposure to hot liquids, electric current, chemical burns, contact with hot objects for extended periods. The skin involvement is going to be the entire epidermis and dermis, sometimes extending to subcutaneous tissue. This may involve connective tissue, muscle, and skin organelles like hair follicles or sweat glands. The clinical, the clinical manifestation is going to be insensate, shock, myoglobinuria, and possible hemolysis in electrical burns. The wound is going to look pale, dry, white, red brown, leathery, or charred. Coagulated vessels may be visible. Edema and eschar will start to form. And our recuperative course and treatment is grafting is necessary for wound closure. Significant scarring and loss of contour and function requires intensive fluid resuscitation, pain management, and infection control. Now we move to deep burn necrosis, 4th-degree burns. This is going to be prolonged exposure to flames or high heat, high voltage electrical injury. This is going to extend into deep tissue, muscle, and or bone. The clinical manifestations here are going to be shock and systemic complications. We're going to have myoglobinuria and hemolysis, charred tissue with possible contact points, entrance and exit wounds, and electrical burns. The wound appearance is going to be charred and blackened. Amputations are often necessary due to the extent of damage. And the recuperative course and treatment is going to be grafting is of no benefit due to the depth and severity of the wound. You want to focus on life-saving measures, infection prevention, and rehabilitation. Amputation and reconstructive surgery may be required. Factors influencing burn depth, again, are going to be the cause of injury, temperature and duration of contact, skin thickness, and blood supply. So, for cause of injury, is this a flame, a scald, chemical or electrical burns? Because they all have different penetration patterns. Higher temperatures and longer exposure times result in deeper burns. Thinner skin in children or elderly are more susceptible to deeper burns. Areas with rich blood supply, like the face, may heal better than areas with poor circulation, like feet. Burn classification is essential for guiding treatment, predicting outcomes, and preventing complications. So now we're going to do another knowledge synthesis. I hope you're enjoying these questions. I have 2 questions for this section. Hopefully this helps and this gets us a little bit better on track. So a nurse is assessing a patient who sustained a burn injury from hot water. The area is red, painful, and has several blisters. The skin blanches with pressure. Based on these findings, how should the nurse classify this burn? Is it superficial? Is it superficial partial thickness? Is it deep partial thickness or full thickness? This is superficial partial thickness because we have red, painful, and blistered skin. These are classic signs of superficial partial thickness, which involves the epidermis and the superficial portion of the dermis. We have blanching with pressure. That indicates microcirculation in the dermis that is still intact. And that's consistent with a partial thickness. And why not the others? So it's not A, because superficial and burns involve only the epidermis and do not blister. Deep partial thickness burns, C, involve the deeper layers of the dermis. They may appear mottled red and white, have less blanching, and are less painful due to nerve damage. Full thickness burns involve the entire epidermis and dermis. The skin appears dry, leathery, and may be white, brown, or charred. There is no pain in the burn area due to the destroyed nerve endings. I have another question for you. A nurse is caring for a patient who sustained a burn injury from a flame. The burn area appears dry, leathery, and white. The patient reports no pain in the affected area. How should the nurse classify this burn? Superficial, superficial partial thickness, deep partial thickness, or full thickness? If you said full thickness, you would be correct. The key findings here are that dry, leathery, and white appearance. They're classic signs of a full thickness burn, and no pain in the affected area. It indicates destruction of nerve endings, which is characteristic of full thickness burns. So now we're going to move into types of burns. Burns are injuries to the skin and other tissues caused by various agents, including heat, chemicals, electricity, radiation, and cold. Each type of burn has unique characteristics, mechanisms of injury, and management strategies. Below is a detailed overview of the different types of burns, including chemical burns, frostbite, traumatic burns, radiologic burns, electrical burns, thermal burns, and burns from traumatic abuse. Chemical burns. Chemical burns occur when the skin or mucous membranes come into contact with corrosive substances such as acids, alkalis, or other chemicals. These burns can cause severe tissue damage and systemic toxicity. The causes are going to be acids, which are found in household cleaners, industrial chemicals, and car batteries. Alkalis found in drain cleaners, cement, and industrial solvents. And then we have other chemicals, which are phenols, petroleum products, and vesicants like mustard gas. Clinical manifestations for chemical burns are going to be pain, redness, blistering, and necrosis at the contact site. Systemic symptoms, which could be nausea, vomiting, respiratory distress if the chemicals are ingested or inhaled. Esophageal burns if chemicals are swallowed, leading to strictures, perforation, and mediastinitis. The management is going to be immediate action. We want to remove the chemical by flushing the area with copious amounts of water, except for dry lime or elemental metals, which react with water. So if the patient has dry lime, you do not add water. That might be a note that you should write down. We want to avoid neutralizing acids with bases or vice versa, as this can cause an exothermic reaction and worsen the injury. If we have an esophageal burn, we want to avoid inducing vomiting or gastric lavage to prevent further damage. We want to administer IV fluids, pain management, and antibiotics if infection is present. We're going to use an esophagoscopy to assess the extent of the injury. And the long-term management may be including esophageal dilation or surgical reconstruction. If you don't know what an esophagoscopy is, you should look it up and understand the nursing implications. Frostbite. Frostbite is a cold induced injury caused by freezing of the skin and underlying tissues. It commonly affects extremities such as fingers, toes, nose, and ears. Frostbite is a burn. The causes are going to be prolonged exposure to freezing temperatures, especially in wet or windy conditions, inadequate clothing or protective gear in cold environments. Our clinical manifestations are going to depend on the level of burn. So I left first degree, second degree, third degree in here so that maybe you could understand a little bit better. You're going to have redness, numbness, and tingling in the first degree. Second degree is blistering and swelling. Third degree is necrosis of subcutaneous tissues. And fourth degree is full thickness tissue destruction, including muscle and bone. So, for management, this is definitely an NCLEX question. And those of you wanting to go into emergency medicine, this is a CEN question. You want to rewarm these. You want to immerse the affected area in warm water for 30 to 40 minutes. That's going to get the blood flowing back there. You want to administer analgesics, as rewarming can be extremely painful. You want to protect the area with sterile dressings, evaluate to reduce swelling, and avoid rubbing or massaging. Complications for frostbite would be monitoring for infection, compartment syndrome, and systemic effects such as hyperkalemia and hypovolemia. Now we move to traumatic burns. Traumatic burns result from a physical injury combined with thermal, chemical, or electrical exposure. These burns often occur in accidents, explosions, or combat situations. Causes to include motor vehicle accidents, industrial explosions, and combat injuries, such as blast injuries. Clinical manifestations are going to be combined features of burns and trauma. So think fractures and internal injuries. High risk for infection and complications due to that compromised skin integrity. Your management is going to be stabilize the patient, focus on those ABCs, treat associated injuries, provide burn care, including wound cleaning, debridement, and infection prevention. Then we move to radiologic burns. Radiologic burns are caused by exposure to ionizing radiation, such as X rays, gamma rays, and radioactive materials. The causes are going to be radiation therapy for cancer. This is super common to treat these patients with burns. They're they pre-treat with like lotions and things to prevent the burns, but sometimes it just happens with that thinner skin. And then we could also have nuclear accidents or exposure to radioactive materials. Clinical manifestations are going to be erythema, blistering, and ulceration of the skin, delayed healing and fibrosis, systemic effects such as bone marrow suppression, and increased cancer risk. The management here is we're going to decontaminate the skin by removing clothing and washing with soap and water, monitor for systemic effects, and provide supportive care, including wound management and pain control. Now we'll move to electrical burns. Electrical burns result from contact with electrical currents, which can cause deep tissue damage despite minimal external signs. Causes here are going to be household electrical outlets, high voltage power lines, and lightning strikes. The clinical manifestations here are going to be entry and exit wounds with charring, deep tissue damage, including muscle and nerve injury. And this is a star. Cardiac arrhythmias or arrest due to the electrical current. Thermal burns. Thermal burns are caused by exposure to heat sources such as flames, hot liquids, steam, or hot objects. The causes here are going to be scalds from hot liquids or steam, flame burns from fire, contact burns from hot objects. Clinical manifestations are going to depend on how the burn is classified. So for superficial, redness, pain, and no blisters, think sunburn. Partial thickness burns, blisters, redness, and pain. Full thickness, dry, leathery, and painless due to nerve damage. I said it right that time. So management, you want to cool the burn um with water. That should say sterile water. So cross out running and write sterile water. We want to keep these patients as clean, as sterile as possible. You never want to put ice on burns. Okay. You're just going to damage the skin that's underneath. You want to cover the burn with a clean, sterile, non adhesive dressing. You want to provide pain management and monitor for signs of infection. For severe burns, you're going to initiate fluid resuscitation using that Parkland formula that we'll get to. And then, this pains me to talk about, but we do have to talk about burns from traumatic abuse because no matter what field you go into, you're likely to see traumatic abuse. Burns from traumatic abuse are intentional injuries. They're often seen in cases of child abuse, elder abuse, and domestic violence. The causes are going to be intentional scalding. So, like immersing a child in hot water. You're going to see like a nice even line on wherever they immersed that child to. Cigarette burns. And then forced contact with hot objects. The clinical manifestations are going to be patterned burns, that glove and stocking distribution and scald burns, delayed presentation for medical care, inconsistent history provided by the caregiver. You want to assess for signs of abuse. Are there any unexplained injuries, behavioral changes? A child who doesn't really interact with you, a child who doesn't smile, a child who is a little withdrawn, those things, doesn't make eye contact with you. Those are all signs of abuse. You want to report suspected abuse to the appropriate authorities, provide emotional support and counseling for the victim, and treat the burn injuries as appropriate. So here's a slide with your key takeaways. Chemical burns are caused by corrosive substances, require immediate flushing and careful management of systemic effects. Frostbite is caused by freezing temperatures. It requires controlled rewarming and monitoring for complications. Traumatic burns result from physical injury combined with burn mechanisms. They require stabilization and treatment of associated injuries. Radiological burns caused by ionizing radiation require decontamination and monitoring for systemic effects. Electrical burns are caused by electrical currents, require cardiac monitoring and assessment for deep tissue damage. Thermal burns caused by heat sources require cooling, pain management, and wound care. And burns from traumatic abuse. They're intentional injuries. They require a high index of suspicion for abuse and reporting to authorities. By understanding these unique characteristics and management strategies, you can deliver targeted care and improve patient outcomes. Back to our friend knowledge synthesis. I've got a couple of questions here for you. A nurse is caring for a patient who sustained a burn injury after spilling a strong acid on their arm. Which action should the nurse take? Apply a neutralizing agent to the affected area, flush the affected area with copious amounts of water, cover the burn with a sterile dressing, or administer IV pain medication. The answer is B, flush the affected area with copious amounts of water. Immediate action for chemical burns is what is required. The priority in chemical burns is to remove the chemical agent from the skin to prevent further tissue damage. Flushing the area with large amounts of water dilutes and removes the chemical. Neutralizing agents are not recommended because they can cause exothermic reactions which will worsen the injury. So it's not A. It's also not C because it's important to cover the burn with a sterile dressing, but it's only after the chemical has been thoroughly flushed away because the chemical will continue burning if we didn't do that. And pain management is important, but it is not the first priority because in acute chemical burn management, getting the chemical off of the skin is what the priority is. The first action is to flush the affected area with water to remove the chemical and minimize tissue damage. Now we have another question. We have a patient presents to the emergency department with frostbite on their fingers after prolonged exposure to freezing temperatures. Which intervention should the nurse anticipate as part of the initial management of frostbite? Massage the affected fingers to restore circulation, apply a heating pad directly to the fingers, immerse the fingers in a warm water bath, or administer a vasoconstrictive medication to reduce swelling. So if you said C, you were correct. We want to immerse the fingers in a warm water bath. The goal is to rewarm the affected area gradually using a warm water bath. This helps restore circulation without causing further tissue damage. Rapid rewarming or direct heat, such as the heating pad, can cause thermal injury and should be avoided. It's not massage the affected fingers, option A, because massaging frostbitten tissue can cause mechanical injury and should be avoided. It's not D, administer a vasoconstrictive medication because vasoconstrictors reduce blood flow, which is counterproductive in frostbite management. We want to introduce blood flow. So now we're going to move to the rules of nines. The rule of nine is a critical tool for estimating the total body surface area affected by burns. It is widely used in clinical practice to guide fluid resuscitation, determine burn severity, and plan treatment. The This section will explain the rule of nines, its application, and importance in burn management. So, what is the rule of nines? The rule of nines divides the body into regions representing approximately 9% or a multiple of 9 of the TBSA. This method allows for a quick and systematic estimation of burn extent, which is essential for initial management and treatment planning. The rule of nines uses body regions and percentages. The rule of nines assigns specific percentages to different body parts as follows. So for adults, the head and neck is going to be 9%. Each arm is going to be 9%. So that's that full arm all the way around, anterior and posterior. Each leg is 18%. So the anterior is 9% and posterior is 9%. That makes sense. The legs are bigger than the arms. Your anterior trunk is 18, your posterior trunk is 18, and your genitalia and perineum are 1%. For infants and children, the proportions differ due to larger head size and smaller legs in children. So, head and neck is going to be 18%. Each arm is 9%. Each leg is 14%. The trunk is 18 for the anterior, 18 for the posterior, and the genitalia and perineum is 1%. And here is an example of the rule of nines for you. So, how do we use the rule of nines? We need to assess the burn and determine which body regions are affected. Then we add the percentages of all the affected regions to calculate the TBSA. For partial burns, we might want to adjust. So if only a portion of a region is burned, estimate that percentage. So like a half of one arm is going to be 4.5%. So clinical application. We're going to use the rule of nines to determine the burn severity. So minor burns is going to be less than 10% TBSA in adults and less than 5% in children. Moderate burns is going to be 10 to 20 in adults and 5 to 10 in children. Major burns are going to be greater than 20% in adults and greater than 10% in children. We use the rule of nines to guide fluid resuscitation. So we'll adapt that to the Parkland formula. So the Parkland formula is 4 mils times the percent TBSA times weight in kgs. And that's used to calculate the fluid requirement for the first 24 hours. And then we also use the TBSA percentage to plan treatment. So burns greater than 20% TBSA often require hospitalization and specialized care. And then burns greater than 40% are life-threatening and may require intensive care. There are limitations to the rules of nines. So accuracy, the rule of nines provides an estimate and may not be precise for irregular or scattered burns. In pediatrics, the proportions differ in children, so a modified rule of nines or the Lund-Browder chart is used for greater accuracy. And then in obese patients, the rule of nines may overestimate the TBSA due to increased surface area. And here we have the Lund-Browder chart for you. This is a more precise method for estimating TBSA, especially in children for age-related changes in body proportions and often used in pediatric burn centers. The rule of nines is a quick and effective tool for estimating burn extent in adults. It divides the body into regions, each representing approximately 9% or multiples of 9. Adjustments are needed for partial burns, pediatric patients, and obese patients. The Lund-Browder chart is more accurate for children and should be used in pediatric burn care, which this is an adult med surg class. We're not going to worry about pediatrics, but I did want to cover it. And then accurate TBSA estimation is critical for determining burn severity, guiding fluid resuscitation, and planning treatment. I have a question here for you for knowledge synthesis. A 25-year-old patient is admitted to the emergency department with burns on the anterior trunk, the entire right arm, and half of the left leg. Use the rule of nines, which is the estimated total body surface area affected by burns. So if you need to pause this lecture and go back to the slide with the rule of nines, use that. So remember, the anterior trunk, the entire right arm, and half of the left leg. If you said C, you would be correct, 36%. The anterior trunk is 18%. The entire right arm is 9%, and half of the left leg is 9%, since the entire leg is 18%. Half of it is 9. Then you want to add the percentages together. So 18 plus 9 plus 9 is 36. It is not 18% because this would only account for the anterior trunk, ignoring the burns on the arm and leg. It is not 27% because this would only account for the anterior trunk and the entire right arm, but it would exclude the left leg. And 45% is an overestimation. And if we overestimate and include additional body regions not mentioned in the question, we can over fluid resuscitate these patients. So the rule of nines is a quick and effective method for estimating TBSA in burn patients. In this case, the burns on the anterior trunk, right leg, and half of the left arm total 36%. This question tests the student's ability to apply the rule of nines to a clinical scenario accurately to calculate burn extent. I have another question here for you. A 3-year-old child is admitted to the emergency department with burns on the entire anterior trunk, the entire right arm, and the half of the left leg. Using the Lund-Browder chart. So again, pause this and go back and get that chart. What is the estimated TBSA affected by burns? If you said B, 32%, you would be correct. The Lund-Browder percentages for a 3-year-old child are going to be anterior trunk is 18, entire right arm is 9, and half of the left leg is 7. Since the entire leg is 14, half of it is 7. You add those up, and then you adjust. So now we talked about how we determine the TBSA, which is one part of the Parkland formula. And now we'll talk about the Parkland formula. The Parkland formula is a critical tool used to calculate fluid resuscitation requirements for burn patients during the first 24 hours after injury. It is essential for preventing hypovolemic shock and ensuring adequate tissue perfusion. You all should be experts in shock after our last class. This lecture will explain the Parkland formula, its application, and its importance in burn management. What is the Parkland formula? The Parkland formula is a guideline for calculating the total volume of intravenous fluids required for burn patients in the first 24 hours post-injury. Parkland formula applies to the first 24 hours post-injury. It is based on the patient's weight and the percentage of total body surface area affected by burns. So this should indicate to you that it is very important in your history taking assessment that you find out when the burn happened. Because if the burn happened 10 hours ago, then we only have 14 hours to infuse this fluid volume. If the burn happened 5 minutes ago, then we have 24 hours. So you need to know health history and when it happened. So the Parkland formula calculation is the total fluid, number of mLs, is 4 mils times kilograms times percent TBSA. You would use the percent TBSA as a whole number here. So, like, don't try to do 0.36 if it's 36%, just do 36. So if we multiply 4 mils by the patient's weight in kilograms and the percentage of TBSA burned, that's how we get the Parkland formula. So an example, a 70-pound or 70 kg patient with 30% TBSA burns would require 4 mils times kgs, so 70 kgs, times 30 for 30% equals 8,400 milliliters. Okay. So that's the number that we have to infuse over 24 hours. We're going to administer half in the first 8 hours. So half of the total volume is given in the first 8 hours from the time of injury, not from the time of admission. That's why I said it's very important to get that health history. So if we were to do 8,400 milliliters in our patient example, we divide it by 2, 4,200 mils in the first 8 hours. We're going to administer the remaining half over the next 16 hours. So the remaining half is that 42 mils. We're going to do that over 16 hours. So again, you have to be sure to calculate that and to know when your burn happened. The fluid of choice is LR, and it is because it closely matches the body's electrolyte composition and helps correct metabolic acidosis. So, why is the Parkland formula important? Why do we have to learn about it? Burn injuries cause massive fluid loss due to increased capillary permeability. We talked about capillary permeability in shock, so you should really understand that. The Parkland formula ensures adequate fluid replacement to maintain circulation. In this situation, we are actually losing the fluid, so we need to replace it. Um, the Parkland formula will guide treatment. It provides a standardized approach to fluid resuscitation, reducing the risk of over or under hydration. There's no guessing involved. You have to remember that this Parkland formula is going to start in the field of where it happened. If a burn is extensive enough where they need EMS, this Parkland formula is going to start there. So, if EMS understands Parkland formula, nursing understands Parkland formula, providers understand Parkland formula, we're all on the same page. And the Parkland formula improves outcomes by reducing complications such as acute kidney injury and organ failure. There are adjustments that need to be made to the Parkland formula. So, pediatric patients have higher fluid requirements due to their larger body surface area. Some clinicians will use 5 mils per kg times TBSA instead of the 4. So, know what your if you get a pediatric patient into your ER or you are continuing the fluid administration from your patient from the ER, then you need to make sure that you understand what the infusion rate should be. For electrical burns, patients with electrical burns may require more fluids due to deeper tissue damage and myoglobinuria. And then for inhalation injuries, patients with inhalation injuries may require additional fluids to compensate for increased fluid loss through the respiratory tract. You want to have careful monitoring during fluid resuscitation. So you want to make sure that the urinary output, the goal is 0.5 to 1 mils per kg per hour in adults and 1 to 1.5 mils per kg per hour in children. You want to adjust the fluid rates based on that urine output. So if you are infusing the Parkland formula in the first 8 hours, and it says to infuse 4,200 mils per 8 hours, and you are not achieving a goal of 0.5 to 1 mils per kg per hour, you need to call the provider and get that order changed. You want to monitor vital signs such as blood pressure, heart rate, and respiratory rate to assess for signs of fluid overload or inadequate resuscitation. And then you want to monitor electrolytes, hematocrit, and blood gases to detect any imbalances. There are complications of fluid resuscitation. We could have fluid overload, where we have pulmonary edema, crackles in the lungs, jugular venous distension, and we would manage that with reducing fluid rates and administering diuretics if necessary. And then we could have electrolyte imbalances such as hyponatremia, hypernatremia, hypokalemia, or hyperkalemia. And we want to adjust fluid composition and monitor electrolytes closely. And then we could have compartment syndrome, which would be severe pain, pallor, pulselessness, paresthesia in the affected extremity. And the management would be perform a fasciotomy to relieve pressure. Our key takeaways here are the Parkland formula is used to calculate fluid resuscitation requirements for burn patients in the first 24 hours. The formula is 4 mils per kg per percent TBSA burned. You will need to know this formula, so please make note of it. Half of the fluid volume is given in the first 8 hours, and half is given over the next 16 hours. And then your lactated ringer solution is the preferred solution for burn resuscitation, and you need to monitor that urinary output, know those goals, vital signs, and lab values is essential to prevent complications. And here is a knowledge synthesis question for you. A 70 kg patient is admitted with burns covering 40% of their TBSA. Using the Parkland formula, how much fluid should the patient receive in the first 8 hours after the burn injury? Pause and figure it out. If your answer was B, 5,600 mils, you are correct. The Parkland formula is total fluid equals 4 mils per kg times percent TBSA. For this patient, we're going to have 4 mils times 70. That's how many kgs this patient is, times 40. That's their percent TBSA. That's 11,200 mils. We're going to administer half in the first 8 hours. So half of the total fluid volume is given in the first 8 hours. 11,200 divided by 2 is 5,600. So it's not 2,800 because that's only 1/4 of the total fluid. It's not 8,400 because that's a total fluid requirement for 24 hours, not the first 8 hours. And it's not 11,200 because this is the total fluid requirement for 24 hours, not the first 8 hours. Parkland formula calculates the total fluid volume for the first 24 hours with the half of the volume administered in the first 8 hours. All right, so now we're going to dive into complications of burn injuries. These are the things that you need to know and mitigate in your burn patients so that we don't get here. Respiratory problems. These are going to be caused by inhalation injury, inhaling hot gases, smoke, or toxic chemicals. If we have an upper airway injury, we could have a thermal or chemical injury above the glottis, leading to edema and airway obstruction. If we have a lower airway injury, we could have a chemical injury below the glottis, causing bronchospasm, mucosal edema, and atelectasis. We could have carbon monoxide poisoning. Carbon monoxide binds to hemoglobin, reducing oxygen delivery to tissues. So, if you have a patient who was in a structure fire, inside the structure fire, you do not get a pulse ox. You get a end-tidal CO2 because a pulse ox is going to be erroneous. Oxygen binds to red cells, and red carbon monoxide binds to red cells. So when you're checking a pulse ox, you're looking for the percentage of red cells that have oxygen molecules binded to them. The pulse ox cannot differentiate between oxygen and carbon monoxide. So carbon monoxide poisoning binds to hemoglobin, and it reduces oxygen to delivery of tissues. We could have circumferential chest burns. This would restrict chest wall movement, impairing ventilation. The immediate emergent treatment for circumferential chest burn, where a patient is not able to breathe, is an eschar-otomy. Please write that down. If you have an NCLEX question where a patient has a circumferential chest burn, the answer is most likely going to be eschar-otomy. Because even if you put these patients on a ventilator, if they can't expand the lungs, you can't improve ventilation. So, clinical manifestations of upper airway injury are going to be stridor, hoarseness, singed nasal hairs, soot in the mouth. If you have any of these with with an inhalation injury, you're looking at intubation. Lower airway injury, wheezing, carbonaceous sputum, hypoxemia. We could have carbon monoxide poisoning. This is going to be headache, confusion, and cherry red skin. That is a late sign and that is a hallmark sign. Our medical management is going to be airway protection, early intubation for upper airway edema, 100% oxygen for CO poisoning. That's going to be on a non-rebreather. Bronchoscopy to assess and clear the airway. Pulmonary toilet is an aggressive suctioning and chest physiotherapy, but eschar-otomy for that circumferential chest burn. You're going to use an eschar-otomy for any circumferential burns. Scarring. The causes of scarring are going to be deep partial thickness and full thickness burns. Damage to the dermis leads to abnormal collagen deposition. We're going to have hypertrophic scarring, which is raised, red, and itchy scars caused by excessive fibroblast activity. That's going to be a keloid. Clinical manifestations are going to be thick, rigid scars that may limit joint mobility, psychological distress due to disfigurement, and our medical management is going to use pressure garments to reduce scar formation, silicone sheets to flatten and soften scars, physical therapy to maintain range of motion, and what should be on and surgical intervention for severe contractures and functional impairment. And what should also be on here is psychological support for these patients. For hypothermia, the causes are going to be loss of skin barrier, so increased evaporative heat loss. Cold IV fluids will lead to hypothermia. Large volumes of room temperature fluids during resuscitation. That's why we always use a fluid warmer. And exposure during transport or in cold environments. So, if you're getting your patient naked because they have a burn, you want to turn up their temperature in the room. The core temperature of these patients is going to be less than 36, so we need to warm them up. Shivering, cold skin, and decreased mental status is what you're going to see. You need to warm the environment using warming blankets, heat lamps, or warmed IV fluids. You want to monitor temperature. You want to continuously monitor that core temperature. And then you want to limit exposure by keeping the patient covered during procedures. These patients are at risk for hypovolemia. We have a capillary leak syndrome where plasma leaks into the interstitium, causing intravascular volume depletion. Then we have inadequate fluid resuscitation, so failure to replace lost fluids. If we have inadequate fluid resuscitation, then we're not monitoring that urinary output. Clinical manifestations are going to be hypotension, tachycardia, and decreased urinary output, cool, clammy skin, and altered mental status. Our management is going to be fluid resuscitation using that Parkland formula. We want to monitor that urine output. Goal is 0.5 to 1 mil per kg per hour in adults. Vasopressors if fluid resuscitation alone is insufficient. Infection. Infection is a very big risk for burns. So the cause is going to be loss of that skin barrier, exposes underlying tissues to pathogens. Immunosuppression, burn injury impairs that immune function because the immune function is trying to fix that skin. And then invasive procedures like IV lines, catheters, and surgical interventions increase that infection risk. Clinical manifestations are going to be fever, purulent drainage, and increased pain. Systemic signs such as tachycardia, hypotension, and leukocytosis. The management is going to be aseptic technique during wound care and procedures. Topical antimicrobials, systemic antibiotics for documented infections because we're going to be good antibiotic stewards, and tetanus prophylaxis if not up to date. Then we could have acute compartment syndrome. This is with circumferential burns. Eschar or edema restricts blood flow, and fluid resuscitation. Excessive fluid administration increases tissue pressure. How do we determine if we have excess fluid administration? We monitor that urinary output. Clinical manifestations are going to be the 6 Ps: pain, pallor, pulselessness, paresthesia, paralysis, and pressure. And then we're going to have increased compartment pressure greater than 30 millimeters per mercury. Management is going to be that eschar-otomy. Surgical incision through the eschar to relieve that pressure. Fasciotomy. Surgical incision through fascia to decompress the compartment. And then we want to monitor perfusion, assess pulses, and capillary refill. Pain is a complication. Causes are going to be nerve damage, inflammation, and procedures. The clinical manifestations are going to be severe, persistent pain at the burn site, anxiety, and distress during procedures. We're going to manage this with pharmacological medications like opioids, NSAIDs, and anxiolytics. We can also use distraction techniques, relaxation, and virtual reality. And then we want to pre medicate before wound care. So, burn injuries can lead to respiratory problems, scarring, hypothermia, hypovolemia, infection, acute compartment syndrome, and pain. Early recognition and management of these complications are critical to improving outcomes. Nurses play a vital role in monitoring for complications, providing timely interventions, and supporting patients through recovery. Got another question for you. A patient is admitted to the burn unit after being rescued from a house fire. House fire is a structured fire. Let's think of what we're gonna do for this patient. The nurse notes singed nasal hairs, red flag, soot in the mouth, red flag, a hoarse voice, red flag, red flag. Which action should the nurse take first? Administer 100% of oxygen via non rebreather mask, prepare for immediate intubation, obtain a chest x ray to assess for lung injury, or administer bronchodilators to relieve a bronchospasm. There is nothing in this question that tells me the patient is having a bronchospasm, so I can immediately get rid of that. And let's think through this process. Are we going to administer 100% of oxygen via non-rebreather mask? There is nothing in this question that tells me oxygenation is our problem. So that leaves us to prepare for immediate intubation or obtain a chest x-ray to assess for lung injury. Well, I don't think we have lung injury at all. We just have signs and symptoms of an upper airway potential problem. I told you that inside a house fire and when you have singed nasal hairs and soot in the mouth, then we have a potential upper airway problem. The only thing that would fix a potential upper airway problem is to prepare for immediate intubation. So the answer is B, prepare for immediate intubation. This is the first action so that we can secure the airway. And I told you why it's not the others. So for this one, I have a Parkland formula again. A 60 kg patient with 30% TBSA is admitted to the burn unit. The nurse is calculating the fluid resuscitation requirements using the Parkland formula. What is the total volume of fluid the patient should receive in the first 24 hours? So we already know that the Parkland formula is 4 times kg times percent TBSA. So 4 times 60 times 30 is 7,200. C. That's the only answer it could be. Now we're going to get into burn injury management. There are 3 phases. Burn injury management is a complex process that occurs in 3 overlapping phases. We have the emergent and resuscitative phase, acute and intermediate phase, and rehabilitation phase. Each phase has distinct priorities, but assessment and management of complications often overlap. Below is a detailed explanation of nursing assessments and priorities for each phase, along with key interventions. So, our first phase is the emergent resuscitative phase. This is the time of injury to the completion of fluid resuscitation. So it's the first 24 to 72 hours. Our priorities are to stabilize the patient, prevent shock and respiratory distress, and assess and treat concomitant injuries and initiate wound care. Our nursing assessments and interventions are going to be our primary survey, which is ABCDE. So we need to assess for patency and signs of inhalation injury for the airway. We need to monitor for respiratory distress, administering 100% oxygen if carbon monoxide poisoning is suspected. That will take care of our breathing. For circulation, which is our C, we want to assess pulses, blood pressure, and capillary refill. We want to insert large bore IV lines for fluid resuscitation. And then for D, for disability, we want to evaluate that neurologic status. And E, for exposure, we need to remove clothing and jewelry to assess burns fully while preventing hypothermia. Then we would move to fluid resuscitation by using the Parkland formula to calculate fluid requirements. We want to administer half in the first 8 hours and the remaining over the next 16. And we want to maintain that urinary output goal of 0.5 to 1 mil per kg per hour in adults. For wound care, we're going to cover burns with clean, dry dressings that are sterile to minimize contamination and reduce pain. Avoid applying ointments and creams at the scene because that's yucky and things will get into it. For pain management, we want to administer IV analgesics for severe pain and avoid oral medications due to the risk of aspiration. Then we want to provide psychosocial support, so provide reassurance to the patient and family, address anxiety and fear related to the injury. We're still in that emergent and resuscitative phase. So again, we're going to talk about fluid resuscitation, wound care, pain management, and psychosocial support here. Then we're going to move to the acute intermediate phase. This is from the beginning of diuresis. So this is 48 to 72 hours post injury to near completion of wound closure. So this is a long phase. Priorities are going to be wound care and closure, prevent and treat complications, and provide nutritional support. So our nursing assessments here are going to be wound care, clean wounds gently with mild soap and water, apply topical antimicrobial agents, and perform debridement to remove necrotic tissue. We want to monitor for signs of infection, use an aseptic technique and during dressing changes, and administer tetanus prophylaxis if needed. We want to provide high calorie, high protein diets to support healing. Consider enteral and parenteral nutrition for patients with large burns. We want to administer analgesics before wound care and physical therapy. Use non pharmacological interventions as necessary. And then we want to encourage range of motion exercises to prevent contractures using splints or functional devices to maintain proper alignment. And then we move to the rehabilitative phase. So this is from major wound closure to the patient's return to optimal physical and psychosocial function. This could take months to years. The priorities here are to prevent and treat scars and contractures, promote physical and occupational and psychosocial rehabilitation, and supports the patient's return to daily activities. Nursing assessments and interventions are going to be scar management. We're going to use those pressure garments to prevent hypertrophic scarring, known as keloids. Use silicone sheets or inserts for difficult to treat areas and encourage scar massage with moisturizers. We're going to do physical and occupational therapy, so continue those range of motion exercises and assist with ADLs to promote independence. We're going to address body image concerns and provide emotional support. We want to refer the patients to support groups. And then we want to teach wound care, scar management, and exercise routines to the family and patient, and then provide resources for long term follow up and counseling. Our key takeaways here are that our emergent and resuscitate phase is the focus on stabilization and ensuring airway patency and initiating fluid resuscitation and managing pain. Our acute and intermediate phase is where we prioritize wound care, infection prevention, nutritional support, and mobility. And then our rehabilitation phase is where we emphasize scar management, physical and psychosocial rehab, and patient education. Here's a question for you. A patient is admitted to the emergency department with burns covering 40% of their total body surface area. What action should the nurse prioritize first? Administer IV pain medication, establish two large bore IV lines for fluid resuscitation, apply silver sulfadiazine cream to the burn wounds, or assess the patient's psychosocial needs. Well, if you said establish two large bore IV lines for fluid resuscitation, you have been listening. Our rationale is that's the priority. The first priority for emergent resuscitative phase is to stabilize the patient and prevent hypovolemic shock. This requires immediate resuscitation using the Parkland formula. Another question for you. A patient is in an acute intermediate phase of burn recovery, develops a fever and purulent drainage from their burn and wounds. What action should the nurse take first? Administer prescribed antibiotics, notify the healthcare provider, increase the frequency of wound cleaning, and apply a new layer of silver sulfite cream. If you said notify the healthcare provider, again, you paid attention. That is the priority in the acute and intermediate phase. Signs of infection require immediate attention. One last one here. A patient in the rehabilitative phase of burn recovery expresses concern about the appearance of hypertrophic scars on their arms. Which intervention should the nurse recommend first? Applying silicone sheets to the scars, schedule a consultation with a plastic surgeon, encourage the patient to avoid sun exposure, or teach the patient how to perform scar massage. If you said D, teach the patient how to perform scar massage, you are correct. The first intervention for hypertrophic scars is to teach the patient how to perform scar massage with moisturizers. This helps soften the scar tissue and improve mobility. Silicone sheets might be effective, but they're not the first line intervention. And a consultation with a plastic surgeon may be necessary later, but it's not the first step. And while it's important to get the patient to avoid sun exposure, it doesn't address the immediate concern of scar management. Our last section of this lecture is burn rehabilitation. This is where we're going to talk about inpatient versus outpatient settings. Burn rehabilitation is a critical component of recovery that begins immediately after injury and continues long after the patient leaves the hospital. The goals of burn rehabilitation are to restore physical function, minimize scarring and contractures, and support the patient's emotional and psychological well-being. Rehabilitation can occur in both inpatient and outpatient settings, depending on the severity of the injury. The patient's progress and their support system below is detailed in this lecture. Inpatient rehabilitation. When is it used? It's used for patients with severe burns greater than 20% TBSA and when the patient requires intensive therapy and close monitoring. It also is used if the patient has complications. Key features of inpatient rehabilitation are a multidisciplinary team. This includes burn surgeons, nurses, physical therapists, occupational therapists, dietitians, psychologists, and social workers. The team collaborates to create a personalized rehabilitation plan. There's also intensive therapy. So there's physical therapy, which is a focus on restoring mobility, strength, and function through exercise, stretching, and splinting. There's occupational therapy, which will help patients regain independence in activities of daily living, such as dressing, eating, and grooming. And then there's also psychological support, where we address the emotional trauma, body image concerns, and coping strategies. There's also wound care and scar management, where regular wound cleaning and dressing changes occur, application of pressure garments, silicone sheets, and inserts to prevent hypertrophic scarring. We can have pain management here, where we administer analgesics and non pharmacological interventions, such as relaxation techniques and virtual reality. They'll get comprehensive nutritional support, high calorie, high protein diets to support healing, enteral and parental nutrition for patients with extensive burns. We'll have nursing monitoring for complications with regular assessments. The advantages here are going to be 24/7 medical supervision, a structured environment, and comprehensive care. Challenges with this are going to be cost. Inpatient rehabilitation is expensive because you have all of these key features. Then we have outpatient rehabilitation. So, when is that used? It's for patients with mild to moderate burns, less than 20%, when the patient is stable and can manage care at home with support, and for follow up care after discharge from inpatient rehabilitation. The key features here are going to be therapy sessions. Patients will attend scheduled PT and OT sessions at a clinic or rehab center where oh, I'm sorry. That is crazy. The focus is going to be on maintaining mobility, strength, and independence. It's going to be home based care. So the patients and caregivers are educated on wound care, scar management, and exercises. The use of pressure garments, silicone sheets, and moisturizers are going to be done in the home. For psychological support, counseling sessions to address body image concerns, anxiety, and depression, again, will happen in the outpatient setting, and they can have referrals to support groups. Pain management is going to be oral analgesics and non pharmacological techniques. Nutritional guidance is going to be a dietitian consultations, but again, it relies on the people in the home to prepare these meals. And then regular follow up appointments will help to assess healing, scar formation, and psychological well being, but it'll be spaced out. The advantages to this are it's cost effective, so it's less expensive than inpatient care. It's flexible, so the patients can continue therapy while living at home. Really encourages family support and participation in care, but it is challenging. There's limited supervision, so patients may not adhere to therapy or wound care routines. There's a hindrance with access to care, so transportation and scheduling can be barriers for some. So that's why it's important to assess for those social determinants of health before outpatient rehabilitation is suggested. There can be delayed intervention, so complications may not be identified as quickly. Um, and there's pros and cons to inpatient and outpatient rehabilitation, but both settings emphasize physical therapy, scar management, psychological support, and patient education to promote recovery and reintegration into daily life. By understanding the differences between inpatient and outpatient rehabilitation, nurses can advocate for the appropriate level of care and support patients in achieving their recovery goals. Last question. A patient with 25% TBSA burns is transitioning from the acute phase to rehabilitation. The healthcare team is discussing whether the patient should continue rehabilitation in an inpatient or outpatient setting. Which factor is most important in determining the appropriate care setting? Patient's preference for being at home, the patient's ability to perform wound care independently, the availability of support at home, and the severity of burns and need for intensive therapy. This is definitely a question where all are the right answer, but there's one that's more right. And the one that's more right is D, the severity of burns and need for intensive therapy. Severity of burns and need for intensive therapy are most critical factors in deciding between inpatient and outpatient patient rehabilitation. Patients with severe burns greater than 20%, which we have 25%, often require inpatient rehabilitation due to the need for close monitoring, intensive therapy, and management under complications. So that's it. That is our lecture. Um, I'm going to stop sharing and um, we will have lots of in class activities to do on Monday, and I look forward to seeing you there.